week of Women's Health Weekly. We took 2 weeks off. We took June 26th off simply because I was feeling lazy and I was trying to get my kids sort of started with their summer. And then July 3rd, of course, we took off because nobody was working that day, and I didn't expect anybody would want to take an hour and sit down and hang out with me and a guest and listen to whatever we were going to be talking about. So once again, welcome back to our Women's Health Weekly. This is our weekly telecast where we bring experts from New York City, from Maiden Lane Medical, from around the world, from around the country, to address women's health issues from a professional, a clinical, a scientific standpoint, so that we make sure that our viewers are getting the best possible information that they can get. I always add that there's, of course, a lot of information out there, but again, we really want people to hear it from the experts. I always add at the very beginning that we have no commercial interests. I do not get paid for doing this. Our guests do not get paid for doing this. Sometimes we discuss products, medications, procedures, and in doing so, we do not get paid for discussing those items either. So I want everyone to have absolute full disclosure. We have no financial interest in doing any of this. So I want to introduce to you a guest that I am absolutely, totally excited to have here, and she has absolutely no idea how long I've been waiting for her to come on. It's awesome. She agreed like instantly to come on and join us this week. Dr. Carol Long-Roche is a gynecologic oncologist, expert in gynecologic oncology and pap smears and abnormalities associated with the cervix, uterus, reproductive tract, ovaries, fallopian tubes. She's a top-notch surgeon. She's a fantastic human being and works at Memorial Sloan Kettering Cancer Center. And I can say all of that about her. And I know she's a fantastic human being because I have known her since she was an intern in OBGYN at NYU. So, Carol, welcome to Women's Health Weekly. I'm pumped. I'm so excited to have you here. It's absolutely fantastic, and I am 100% sure, we are going to have an awesome conversation today.
Well, thank you so much, Ken. I'm really honored to be here. I really love to interact with patients, even if it's in this digital way, and educate as much as I can. And I can't believe how long ago it was that we were together as an intern.
You don't have to date yourself, but how long ago was it that you were an intern?
It was in 2005.
Seems like yesterday. It really does.
Yes.
It really does.
Well, thank you for having me.
Yeah, welcome. So we're going to talk today about pap smears. And what a mundane topic, but what not a mundane topic, what a cool topic, and what an important topic. And if there's been any way over the last 2 or 3 decades that women's health has been significantly paid attention to, significantly improved, it's in the area of a place where we can actually prevent cancer. And that's what's cool about pap smears, is we have a way to detect and prevent a cancer that's a non-invasive way. So I'm going to stop talking, actually, because this is why I brought you on here. I could talk, but I brought an expert on here so that we could have a conversation about this. All right, so I'm just going to ask a bunch of questions because you can explain all this stuff to our audience a whole heck of a lot better than I can. All right, let's start with the basics. Because when we talk about pap smears, I want to know, and I want everyone to know, what is a pap smear and where is it done and how is it done?
Yeah, so just to echo what you said, I always tell patients that I would love to be out of a job as an oncologist, and I would love to focus just on preventing cancer. And I think pap smears and the whole sort of realm of cervical cancer prevention is one area where we've really succeeded in that. So it is an exciting topic to talk about. The cervix is really just the lower part of the uterus. It's the opening to the uterus. It's the part that is accessible at the top of the vagina. So when a gynecologist examines the cervix, it's usually done with a combination of a speculum exam, and the speculum is the instrument that is inserted into the vaginal opening and that is opened slightly to reveal the outer portion, the visible part of the cervix. The cervix then extends up and really just sort of becomes one with the top of the uterine body. And the other way that the cervix is examined is during the bimanual or internal part of the exam, where the gynecologist palpates the cervix and feels for any abnormalities. So the examination is both visual and palpable. And a pap smear is when the gynecologist takes a little sample from the outside portion and the canal portion of the cervix, and those cells can then be examined by a cytologist, who is a pathologist with extra training in examination of cells, to look for any abnormalities or precancerous changes.
So somebody gets the pap smear, somebody takes the sample, packs it up, sends it off to a lab, the laboratory result comes in, and then it's communicated somehow to the patient. As usual, we're getting fantastic questions from our YouTube audience. We'll hold off on a couple of those questions now while we sort of lay the base for what we're talking about. Okay, so we throw this term around a lot. I hear it all the time. Of course, I understand it professionally, but once again, want to hear it from the experts. 3 letters, HPV. What does that stand for? What is it? What does it mean? What does it do? Does it, drive cars and walk around, or is it something people should be worried about?
So that was going to be the next thing I was going to bring up, because in modern times, along with that examination of the cells in the cervix, for certain women, the HPV test is also ordered at the same time and is done on that cervical swab sample. The HPV test tests for an infection called the human papillomavirus, and the HPV virus is a very common human infection. It is an infection that people acquire through sexual activity, but I think we really need to do a lot of work to destigmatize this infection because it's so common. Depending on what study you look at, in some populations, up to 80–85% of people will be exposed to and will be infected with the HPV infection over the course of their lifetime. Where it becomes very relevant is that we know that the HPV infection can, in certain people, cause precancerous changes in the cervix, and then in certain people with precancerous changes, actual invasive cervical cancer can develop from those. And so the HPV test serves as almost a flag to us as gynecologists to tell us which patients are at higher risk for developing cervical dysplasia, which is another word for precancer or cervical cancer.
All right, so I don't want to freak anybody out. I don't want people to think just because they have HPV, they're going to get cervical cancer. So I'll ask you the question: if I've been diagnosed, if I'm a woman, which I'm not, but if I am a woman, or a man actually, because men get HPV as well in their penises. So if I'm a woman and I've been diagnosed with HPV or have been positive for HPV, does that mean I'm going to get cervical cancer?
It definitely does not. And as I mentioned before, the rates of HPV exposure and infection are very, very high in the population. More people than not have been exposed to HPV. But obviously, the rate of developing a cervical cancer is quite low. So within the group of patients that have HPV or have had HPV, some people will actually get the virus, and then their bodies will clear the virus on their own. Other people will get the virus, and the virus will lay dormant in the body and will not cause these precancerous and cancerous changes. But then there are people in whom the virus can be persistent, and over time, that viral persistence can lead to these changes that can be harmful and dangerous. And yes, this is a problem both for men and women. Men certainly can transmit the virus to their partners, but men are also susceptible to other HPV-associated cancers like penile cancer, anal cancer, and many head and neck cancers. And so even though routine HPV testing is not a part of men's health, it is very relevant. And so for example, non-gynecologic tip, dentists will do oral cancer screenings to look for HPV-associated oral head and neck cancers for both men and women.
Interesting. Got it. Maybe I should have, my wife's a dentist. Maybe I should have her on here. We can talk about HPV and head and neck cancers detectable by dentists.
Yeah.
Okay, so you said something that kind of piqued my interest. You said that HPV is transmitted sexually. If a woman has HPV, does that mean she also has other sexually transmitted diseases?
It does not mean that. However, a routine part of any gynecologic care is discussing with your doctor any risk factors you may have, such as a new partner, a new sexual experience, that may warrant concurrent testing for other sexually transmitted infections. And this ongoing relationship with your gynecologist will really ensure that you're getting access to all these tests, which can really be a part of keeping people healthy.
Okay, so I'm going to ask the corollary question, which is how can I prevent myself, if I'm a woman, how can I prevent myself from getting HPV? What do I do there?
Yeah, this is one of the hardest questions that I'm asked in my practice. Unlike some sexually transmitted infections, which we say, use condoms to prevent sexually transmitted infections, condoms don't work perfectly for HPV prevention, meaning even skin-to-skin contact, using a condom for contraception and infection control can still transmit HPV. Outside of limiting sexual partners or encounters or monogamous relationships, there is really no surefire, and even that's not surefire way, because even if your monogamous partner has HPV, it can be transmitted. So we really don't focus as much on the prevention in terms of activity. What we do focus on is vaccination. And so we do have a vaccine against HPV. And to me, as a cancer doctor, this is just the most exciting thing, because this is essentially an anti-cancer vaccine. And if both men and women are vaccinated against HPV, that can actually prevent the transmission if someone is exposed.
All right, so HPV vaccination is, to us as physicians, not necessarily at all even remotely a controversial topic. We wish 100% of people got this. Who should get an HPV vaccination? And if there's a particular type of person who should get it, how old? When does that occur? How does that work?
So as with everything, the sort of indications and guidelines have changed over time as we've learned more. Right now, this is actually a vaccination that should be first offered in the pediatrician office. So in the United States, we recommend that boys and girls around age 11 or 12 be offered the HPV vaccine. It's understandable that people are concerned. I'm a parent, and so I understand it's hard to, give anything to your healthy child, but this is actually one of those things that really can protect their life and their fertility and all sorts of things. So that's the first place. But if a person hasn't received the vaccine as a child, it's something that they can talk to their gynecologist about. The current guidelines cover HPV vaccination up to age 45, but there's really no reason why it couldn't be considered outside of that for select patients. And in my practice, we really offer it to anyone who would like it. It is a safe vaccine. There are always anecdotes of people who have had bad experiences, and I acknowledge that and empathize with the fear that comes from that. But the scientific data supports that other than some transient, soreness in the arm or some mild symptoms, that it's very safe.
So I understand what you're saying. I have myself an 8-year-old daughter, as do you. So we get the parental anxiety that goes along with sort of equating getting a vaccine against a virus that's generally sexually transmitted. And then the next thought is, well, my daughter's not having sex, and no, for sure, my 8-year-old daughter's not having sex, but at some point she will, and
Yeah.
that's going to happen. And as a parent, I want to do my best to protect her
Yeah.
when it comes to getting these things, and I don't want her to get cervical cancer. That's for sure.
Yeah.
All right.
I agree, and I would say that as someone who feels very passionately about my patients and taking care of them, the pain and suffering and loss that people experience with a diagnosis of cervical cancer is really devastating. And I think that for me, who sees that and treats that and feels, again, very compelled to prevent that whenever I can, I think it's a pretty reasonable trade-off.
Agreed. Okay, before we jump into some YouTube questions and on to our next topic about pap smears, I just want to remind everybody, welcome back to Women's Health Weekly. We're here broadcasting from New York City on YouTube with Dr. Carol Long-Roche from Memorial Sloan Kettering Cancer Center, who we're very excited to have. Please don't forget to subscribe to our YouTube channel, look for our podcast and our short videos that will come after this with some very, very specific topics that we're discussing. Okay, let's hit some of the questions that our awesome YouTube audience has asked us. Rosie, who is 24, is used the term, she's devastated that her pap smear recently came back as ASCUS. And I know you're about to explain what ASCUS is. Came back as ASCUS, and she has a high risk positive, not 16 or 18, HPV. Take me through that. What does that mean? What does all that mean? I mean, that's she obviously has a technical, sounds like a technical understanding. Her doctor probably told her this.
Yeah.
Let's take her through it. And her corollary question is, how long does it take for HPV to become ASCUS, and is that important?
Yeah, we think that the data that we have is more from how long it takes an abnormal pap smear to become invasive cervical cancer. And we do think that that period of time is probably pretty long, measured in terms of years. And what that offers us is an opportunity to intervene. And I'm sorry that you're devastated, and I empathize with that, but I would challenge you to try to think about it as a real opportunity to keep yourself healthy, and partner with your gynecologist to take this information that is scary and upsetting, but turn it into really the opportunity to stay well and prevent something that could be much worse. ASCUS stands for atypical squamous cells of undetermined clinical significance. And what that means is the cytologists, when they looked under the microscope, saw some changes. And the changes, they couldn't quite be sure whether these changes were benign, like from inflammation, or whether these changes were from the start of some precancerous type changes. Everyone who has precancerous changes doesn't go on to develop cancer, and the pap smear is really how we ensure that by getting the information. The next step after an abnormal pap smear is then to do a colposcopy, where the gynecologist uses basically a fancy microscope to look very closely at the cervix and look at the cells, and to identify whether there's any visually concerning lesions. And then in many cases, take a little biopsy of tissue to then give to the pathologist to look for precancerous changes. Depending on the type of precancerous changes, we may just watch, because many women, especially 24-year-old women, their bodies will actually heal those changes on their own. However, if the changes are severe, then it may be that an intervention is needed, where a little bit of tissue is excised from the outside portion of the cervix, hopefully excising the abnormal cells and treating the problem.
That's a great message, an opportunity to pay attention to your wellness and really take great care of yourself. I have a corollary question, but I want to get to another YouTube viewer question. JH wants to know if there's an HPV 16 history, and now I don't know how old JH is, but JH asks if there's an HPV 16 history and the last few PAPs have been negative, but ASCUS, any need to be concerned about that?
I mean, I think that, if you are under regular care from your gynecologist and they are, aware of your history and they have your pap smears, there's very specific guidelines that every gynecologist has access to about, how to plan the next step, what the next pap should be, when it should be. So as long as your gynecologist has you within those guidelines, I would trust that you're getting proper care. In terms of the history of HPV-16, any history of HPV or HPV high risk or the highest of the high risks, which are the 16 and 18, just means that relationship with your gynecologist and that adherence to the pap smear guidelines is that much more important. Wouldn't be concerned so much, but the need for diligence is there, because if an abnormality is found, it can be treated early and cervical cancer can be prevented.
So JH is 41, and I don't think your answer would change.
No, I think any woman with a history of any HPV or abnormal paps, again, it just solidifies really the importance of regular follow-up and communication. And of course, if you feel like you're having a symptom that's not being addressed, to really push forward and make sure that that's being, evaluated properly.
All right, Dr. Long, I have one more question, and I'm going to, this is from me, because I get this question all the time in the office, and you mentioned wellness and taking good care of yourself. HPV is a virus, and as such, it's an infection. So are there things that women can do to take care of themselves, to give themselves, so to speak, in quotes, a healthy immune system, and potentially prevent it from infecting them, even if they are exposed?
Yeah. So, I always remind my patients that our bodies are human, and we are susceptible to viruses, as we know now. Right, like we're experiencing in a completely unprecedented way right now.
Right.
But when it comes to the HPV infection, you can do everything right and still have dysplasia. You can be super healthy with a robust immune system and still have dysplasia and cervical cancer. And you can do everything wrong and not have it. So there are some things that are out of our control. However, with that said, healthy lifestyle and decreasing some known risk factors are really important. So one thing is smoking. We know that if a patient has HPV and they are a smoker, that they are much more likely to have precancer and cancer. So smoking is a big thing. Things that are another big thing is the vaccine. So we all have, that's something that we can all do. And actually in our clinic, we all gave each other the vaccine when the age guidelines changed. So we all got it together here in my clinic. The other things are a little less data driven, but I think most of us believe in them, which is things like stress reduction. So getting a good amount of sleep and eating a healthy diet, focusing on whole foods and trying to limit, things that are common sense would tell you are unhealthy. Even women who have had dysplasia, there's now some evidence that getting the vaccine will prevent that dysplasia from coming back. And then there are some holistic things that have actually been studied in a pretty rigorous way. There is a mushroom extract supplement that data was recently presented at our 2019 Society for Gynecologic Oncology meeting, that it decreased the recurrence of cervical related problems. So that would be my suggestions. Don't smoke, see your gynecologist, get your vaccines, and then of course, general healthy lifestyle, exercise, good sleep, healthy diet.
That's great. Thank you. She always gives such an amazing, comprehensive answer. I love it. And you spend a lot of time with your patients, I know, because my patients that I've sent to you tell me that Dr. Long-Roche is great. She spent a lot of time explaining things to me, so I would expect nothing less. One more question from our YouTube viewers here. Okay, back to somebody just asked, what's the name of that? If you know the name of the mushroom extract, great. If not, no worries. I'll post it later.
I printed it because I knew that would get asked. It It's a hexose correlated mushroom supplement.
Hexa, I'm going to write that on our Hexos.
Mushroom extract. And this is data driven. I don't know if the paper has been published, but but we can get it out to people. And again, it's not something that I have any stake in. I actually really more focus on the other things, but I think if people really want something to complement the things that they're working with their gynecologist on, this is something that can be done. And the study that was done on it showed no adverse effects from it.
It may not even be branded yet. It may
yeah, I don't know
tough.
if it's
it may
even
be hard
branded.
to get over, in a health food store.
Okay.
All right. So my last question for this part from a YouTube viewer: if you have HPV high risk positive but not 16 or 18, and the follow-up colposcopy was completely normal, no abnormal cells, what happens next? Do you just monitor?
So,
That's from Mo.
Like I said, there are very specific guidelines. If the follow-up is normal and there's no dysplasia identified, then you sort of channel right back into that surveillance algorithm. And like I said, there's very, very specific guidelines for every situation. And so depending on that person's age, and their pap history and sort of where they are, their gynecologist will recommend the next step, which in that case sounds like it would be another pap with HPV testing at a certain interval depending on the person's age.
All right, so before we get to the next section, once again, Women's Health Weekly here from New York City, experts from Maiden Lane Medical, New York City, around the country and around the world. We're here today with Dr. Carol Long-Roche, who is a gynecologic oncologist, expert in gynecologic oncology, HPV, pap smears, and everything associated with it, who is at Memorial Sloan Kettering Cancer Center. Okay, so you said a word earlier, dysplasia, which I think you said was the precancerous cells. Great. Okay, so I'm going to ask you a ridiculous broad question. Well, actually, let me start with the precursor to the question is, because you mentioned there is a somewhat of a known timeline to potentially getting one of the high-risk HPV subtypes, and then possibly if you're someone who's going to progress to invasive cervical cancer. Is there sort of a similar timeline developed for when you would get exposed to when it would get detected, which I know are two different things, to when you would potentially develop cervical dysplasia?
Yeah, it probably is also measured in terms of years. I think that data is a little harder to comment on because in many cases, HPV testing doesn't even start until a woman is in her early 30s. And so I don't have a great answer to that, but it is probably measured in the sense of years.
Okay, so if I'm a woman and I've been diagnosed with cervical dysplasia, what do I do? Should I be worried? Should what's the skinny on that?
Cervical dysplasia can be mild, moderate, or severe. And depending on the situation, the age of the patient, their desires for, fertility, as well as the type of cervical dysplasia, in some cases with low-grade cervical dysplasia or mild cervical dysplasia, you can just continue to observe. But for higher grade cervical dysplasia, very often a excisional biopsy is needed. And that is what I referenced earlier, where a portion of the cervix, a small portion in many cases, is excised to remove those abnormal cells and also to give the pathologist a little more tissue to examine to make sure that there's no cancer.
So you remove part of the cervix? Is that okay?
Yeah,
is that okay?
It is. It is something that needs to be done, after careful discussion. There are various techniques for how to do it. And certainly you need to have a good partnership with your gynecologist. If you're a woman who's hoping to have pregnancies in the future, or a patient that's hoping to have pregnancies in the future, then, care needs to be taken to take as small as is needed portion of the cervix, but the cervix is about 4 centimeters long. So you can remove a small part of it and it can still function for reproduction.
So can I have pregnancy complications if I have part of my cervix removed?
You can. There is a slight increased risk of pregnancy complications with these excisional biopsies. Things like preterm labor or problems with the cervix being scarred or the cervix being not holding onto a pregnancy. However, with one excisional biopsy or even properly done 2 excisional biopsies, the risks are small. And I would say that, and I always remind my patients of this, the risks of cervical cancer to a woman's fertility are much greater than the risks of an excisional biopsy if needed.
Yeah, it's my understanding even that, you know, when we talk about preterm labor in association with a woman having had a LEEP or an excisional biopsy of the cervix, we're not talking about 25-week preemies for one LEEP. Where the vast majority, to my understanding, of preterm deliveries that occur in women who have had an excisional biopsy occur between 36 and 37 weeks.
Yeah.
Which is you know, which confers a high degree of health and wellness, even though there can be some complications at that gestational age. 37 weeks is actually considered full term.
Yeah, most people will go on to have normal obstetrical care and outcomes.
Okay. So what if I am totally fearful? I may be someone who doesn't necessarily want to have a surgical procedure. I may have received 2 or 3 opinions advising me of that, and I still may not want an excisional biopsy. And just to be clear, I'm putting this question to Dr. Carol Long. I kind of already know the answer, and I always encourage patients when they have certainly moderate or high grade cervical dysplasia to have an excision. But there are a subset of patients out there who don't want that. So I'm going to pose the question, are there any potentially complementary or alternative therapies that have some level of efficacy?
So we do have some, there is some evidence that using the HPV vaccination can help to treat cervical dysplasia. Many times that's done in the setting of a small excisional biopsy, and then the vaccine is given, and that increases the chances that it doesn't come back. There was a study done that looked at the use of a newer vaccine that's not out on the market to actually treat these lesions, and instead of doing an excisional biopsy. That is still in the experimental phase. There are some other techniques like ablations. As an oncologist, I don't use those as often because for us, excision and getting pathology is really an integral part of the care. And there are some select situations in which moderate cervical dysplasia can be observed and very closely, and to see if it can regress on its own. And like with anything, you know, patient autonomy is key, and patients need to hear the risks and benefits of all of their choices. And, you know, if a patient chooses to do something that isn't what we recommend, we can still support them through that and make a good treatment plan. But of course, you know, it's our job to present the facts.
Yeah, I certainly agree with that, and that's definitely the way to go with all of our patients. And yeah, we just, you know, because in the early part of my career, I was at the same place where you did your residency, but you know, ever since I came to NYU in 2001, I had completely abandoned, and maybe this was Dr. John Curtin's doing, completely abandoned cryo, anything for any type of dysplasia, with the understanding that you don't have a tissue specimen, you don't have anything for the pathologist to read, and there are times when the colposcopy biopsies are in fact incorrect and the entire excisional biopsy is normal.
Yeah, that's true. And, you know, I think that the difficult thing about the cryo procedure, it is something that is commonly used in lower resource settings where patients don't have access to an excisional biopsy in other countries, for example. But from my perspective, one thing that isn't talked about as much with the cryo is that it can make further monitoring very difficult. So patients can have cryo, and then sometimes we can't monitor the cervix as closely. But, you know, again, these are all things that are important parts of the conversation.
If I'm a woman talking to my gynecologist about whether or not to do this procedure, what the issues are there any critical questions that I should be asking my gynecologist?
I think that if there is a dysplasia diagnosis and the next steps are being discussed, I think first of all, the desire for future pregnancies needs to be a huge part of the conversation. And I also think, you know, risk benefits in weighing the long term. I mean, there are women who have completed childbearing who might be having multiple colposcopies and pap smears and excisional biopsy recommendations, and they may choose to have a hysterectomy and remove the uterus and cervix altogether, because that risk may be lower to them than the ongoing stress of the surveillance. To other patients, they want to keep their uterus and cervix, and so they would prefer to go that route. So I think just really understanding a patient's values and goals and what's important to them and what risks and they are willing to tolerate is really the most important part. So I just think an open dialogue is the best.
So you mentioned earlier resources, and you mentioned that there are places where patients don't necessarily have access to the wonderful system and the wonderful physicians and technologies and techniques that we have here. I mean, New York City for one, but certainly there may be other parts of the U.S. where those resources aren't available. Let's talk about some of that either those health disparities that are associated with either lower income areas or countries that are not as well off.
Yeah, I mean, I think that certainly in terms of the planet, there are countries that don't have access to regular pap smears, to gynecologists and gynecologic oncologists and procedures. However, interestingly, some of those countries are actually doing better than we are with HPV vaccinations. Rwanda is an amazing example. They used a community health worker strategy to increase the vaccination rates, and they have increased their HPV vaccination rate in girls to 93% of the population. And so we expect to see a drastic decline in cervical cancer there. Interestingly, they don't give the HPV vaccine as readily there to boys because they don't have access to it like we do. They need to save it for the girls. Other countries like Australia has really done a great job of getting HPV vaccines out. I think in the US, we have a lot more fear about vaccines, and that's limited us, even though we actually have access, ready access to it.
Sure.
But we do still see disparities even within our country, socioeconomic status and racial disparities that we as providers need to make more efforts to overcome. I think that there, unfortunately, is a loss of trust. Probably some is valid, but some of it maybe is just people have had bad experiences. And so we need to regain trust, and we need to increase access to healthcare and access to these strategies that can keep people healthy.
So I mean, across healthcare, we understand. We did a show on this with, do you know Terry Ann Bennett? Do you remember her? She was at NYU probably sometime after you. We did a show with her on. We spent the whole show really talking about racial and ethnic disparities in healthcare. So we know that across healthcare and across women's health specifically, there are certainly inequities and racial and ethnic disparities in healthcare. How does that in the United States, how does that look for Black and Hispanic women in the United States?
Yeah, well, one thing, and this is a little bit of a tangent, but we know that Black women are much more likely to be diagnosed with uterine cancer at a later stage than white women. And I think some of that is that we need to do a better job of listening to patients when they come in with symptoms. And I think that we have not done a good job of listening to patients equally. And so there are certainly disparities in, and I think that also can be extrapolated to cervical cancer and dysplasia, that women of color and patients of color Black women especially, unfortunately have worse outcomes because of these healthcare disparities. And we all need to acknowledge it and do a better job and do our own learning. And as a person, I'm doing it, and we're trying to do that here at Sloan Kettering, and hopefully we'll get better.
Yeah, I think everybody's, at least people in healthcare, are starting to be. I hate to use the Brooklyn millennial term woke, but I think everyone's in quotes.
I live in Brooklyn, so
Yeah, I know. Starting to say woke, and as such are starting to realize the dangers associated with implicit bias, and are starting to do self looks and look at our system and look at our education and training and do our best to train that out of. It's impossible to train it out of human, because we're humans and we're going to have implicit biases. But it's a lot of that training that's going on in healthcare is bringing those subconscious implicit biases to the conscious level. And once a normal caring physician understands at a conscious level that implicit bias is existing in interaction, they're far less likely to create a negative outcome because of that implicit bias.
yeah.
So I think that's a good sort of place to start. We had a great conversation today.
Yeah, thanks
A fantastic chat about everything HPV, pap smears, cervical cancers, carrier, amazing. We could talk all day about this stuff, and I know how much you deeply care about your patients, and I know how much your patients really appreciate what you do for them. This has been Women's Health Weekly. From New York City with Dr. Carol Long-Roche from Memorial Sloan Kettering Cancer Center. I know she's busy. Feel free to give her a call on her. She likes calls on her cell phone. No, I'm just kidding. Make a call and make an appointment with her. Please subscribe to our YouTube channel. Don't forget about our podcast. Next week we're doing a total 180 next week. We haven't decided it's either natural beauty products or we're going to do weight loss and nutrition, and a revisit on that. Once again, thank you, Dr. Long-Roche, for your time. I wish everybody a wonderful, healthy, and safe, and hopefully somewhat dry weekend. Thank you very much, and God bless all.
Take care, Ken. Thanks.